Pancreatic pain is another classic type of pain, occurs in 90% of patients where the tumour is in the head of the pancreas, but is unfortunately a late feature of pancreatic carcinoma occurring in the body or the tail of the pancreas. This makes for a late diagnosis, and usually by the time that the patient presents with symptoms, the disease has already spread widely. Pain is usually in the upper abdomen, in the epigastrium, classically made worse by lying in a supine position. Pain often radiates into the back, usually at the level of the upper lumbar or lower thoracic region. Pelvic pain can be associated with rectal carcinoma basically, and in women obviously significant disease involving the female reproductive tract, classically cervical carcinoma. Iliac fossa pain is usually unilateral and associated with adherence to the pelvic wall, and classical presacral recurrence often leads to a lumbosacral plexopathy, and then pain can be referred down to the perineum or external genitalia. Rectal pain can sometimes be described as a mild pressure pain, but can be severe enough for the patients so that they find sitting extremely uncomfortable. Some patients, on the other hand, find that pain can be worse when they actually stand or after walking. And tenesmoid pain is the pain where there's a sensation of rectal fullness, which is actually painful, and it's usually related to local or unrestricted tumour in the rectum or presacral recurrence of rectal tumours. Pelvic pain with an early onset after perineal of perineal pain after AP resection is usually related to the surgery. So, for example, if the patient has surgery and then within a matter of weeks to months they're still having ongoing problems with pain, you would be thinking of surgical pain rather than recurrent pain. If the pain comes on after they've had a period where they've been pain-free, so classically 3 to 6 months, then one would be very suspicious that they've actually got recurrent disease. So in the majority of patients with recurrent disease, it's made worse by raised intra-abdominal pressure and sitting. A significant proportion of these patients respond to a combination of opioid and non-opioid analgesics. If it's possible though, and a patient has had perhaps a rectal carcinoma and they have not had radiotherapy treatment, so they've had a total mesocolon resection at the time of their surgery and radiotherapy wasn't thought to be needed. Post-operatively, if they then go on and get recurrent disease, then radiotherapy is a very reasonable option in terms of controlling their disease and their pain. If there's bladder involvement, there may be significant bladder spasm, and therefore antispasmodic drugs can be useful in these patients, as can drugs for neuropathic pain. Bladder pain is often in the suprapubic area, and in males can be referred down into the penis as well. So the pain can be caused by cancer, whether it's primary or recurrent. Various forms of treatment, such as an indwelling catheter or post radiotherapy, or perhaps even concurrent causes such as infection. One needs to think about the possibility of post-operative pain in the patients. For example, post-thoracotomy pain and post-mastectomy pain. Patients who have radical neck dissections can also have significant issues with neuropathic pain. These pains usually occur following on after surgery, and if once again there's a space between the surgery and the onset of the pain, then one has to seriously think about local recurrent disease. If the patient is otherwise well, in that there is no evidence of recurrent disease, then one needs to think of referring these patients on reasonably promptly to address their chronic ongoing neuropathic pain problems. As I mentioned previously, pain can be related to the treatment of the cancer. Mucositis can be quite severe with radiotherapy and some types of chemotherapy, and in some patients who get severe oral mucositis, they may not be able to eat solids or even drink fluids and may require hospital admission with IV fluids and opioids. And mucosal growth factors have been developed and undergoing trials, and hopefully they'll be available in the not too distant future for use. Peripheral neuropathy can be another problem which is usually associated with the cytotoxics. Classically the vinca alkaloids like vincristine, but other drugs that are commonly used such as the taxanes and perhaps less commonly now cisplatin can also be associated with significant chronic disability. Radiation plexopathy and myelopathy and radiation-induced peripheral nerve tumours can occur, but usually the radiation oncologists are extremely careful in terms of the doses that they use in these areas. However, in a patient who's got very advanced disease, then recurrent treatments may be given, even though there's a much greater risk of plexopathy, particularly if the prognosis of the patient is going to be quite short. So hopefully the benefits will outweigh any risks of this occurring. One needs to also remember that the patients may have other significant comorbidities, and ischemic heart disease is very common, particularly in the elderly population. And if a patient complains of chest pain, then one needs to think of the possibility of angina type pains, particularly if it's the classic pain of heart ischemia. Arthritis is very common, particularly osteoarthritis, rheumatoid much less so, and the patients may be taking anti-inflammatories to control this pain, particularly anti-inflammatory drugs, and in the case of rheumatoid arthritis they may actually be on corticosteroids and slow-acting anti-rheumatoid drugs as well. Patients with vascular disease can also have significant issues with peripheral vascular disease. Patients may have had previous vascular surgery or had sympathectomy. And gastroesophageal reflux disease is also extremely common. Patients may be on proton pump inhibitors or H2 blockers. Pain may be caused by just the debility of the patient, and I guess the most worrisome of these is probably pressure areas, and obviously for a palliative care patient they need good basic nursing care to try and prevent these, because once you get pressure areas and pressure ulceration, it can be very difficult to nurse the patient. Other pains related just to debility include constipation and reflux, gastroesophageal reflux, bladder spasm if they've got an indwelling catheter or infection. If a patient's bedridden or mobility is poor, particularly in the setting of advanced cancer, there's a much greater risk of thromboembolic disease. Musculoskeletal pains we've already mentioned, infection from various causes, but particularly bladder infections. If a patient has a previous history herpes infection, they may have post-herpetic neuralgia, and that can be an ongoing chronic pain. Mucositis we've already discussed. In terms of headache is a common problem, and in the cancer patient it's most likely the cause of the headache is not related to their underlying malignancy. But if there are neurological signs or symptoms in that the patient's demeanour has changed, or they've had any personality change, or they've had memory issues, then that is a hallmark of potential space-occupying disease. But then certainly if they've got any significant signs that are local signs, then one has to obviously think about structural disease. It can be a side effect of chemotherapy, and of course if a patient's had lumbar puncture or just a fever, then there's increased risk of actual headache.